Interesting webinar under the aegis of Mumbai Hematology Group. This time it is on novel targeted therapies on acute myeloid leukemia. And I must compliment our program director, who has been successfully running the longest web series probably at a global platform, if not the longest, probably one of the longest. Professor Dr. M.B. Agarwal, sir, an institution in himself, inspiration to many, and in India is fortunate to have him, who has enriched us by his collaboration with stalwarts in hematology across the globe. One of them you would see again today, bringing them on virtual platform every weekend, every Saturday and every Sunday. No wonder, sir, you have received many awards and accolades, including the Inspiring Hematologist of India by Economics Times. May I request you to take it forward from here, sir?
Thank you, Dr. Manoj. Dr. Prakash, can you mute yourself? There's a lot of background noise. Yeah, thank you so much. Thank you. So, good evening, friends, and good morning and good afternoon if you are from other part of the world. Today, our guest speaker is once again Dr. Wang from Buffalo. She's going to speak to us on novel targeted therapies for AML. This webinar is brought to you by MHG, supported by INTAS, and managed by Perfect Square. I thank Dr. Manoj Kumar and the team from INTAS. They've been always supporting our academic activities for the last 3 years, and of course, prior to that, all the in-person meetings. Mr. Yash, Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. And once again, we're extremely grateful to our guest speaker, Dr. Wang from Buffalo. She has been our regular speaker in these webs. I've lost the count. This is the third, the fourth, or the fifth time she's speaking to us. She has never said no to us whenever we approached her to educate us. All our discussants were themselves eminent hematologists or medical oncologists, and you participants for sparing your Saturday evening, morning, or afternoon. We have today participation from 27 countries across the globe. Tomorrow morning at 11:30, we have Dr. Bruno speaking to us on autoimmune hemolytic anemia. He is from Department of Hematology, University of Milan. Discussants today are very important personalities across the country. They've been put up alphabetically here. I'll very briefly introduce them to you. We have Dr. Abdul Majid from Kozhikode, Dr. Chandrasekhar from Vizag, Dr. Deep Mala from Lucknow, Dr. Fahima Hassan from Lucknow, Dr. Hemant Malhotra from Jaipur, Dr. Lalit Mohan Sharma from Jaipur, Dr. Mona Vijayan from Lucknow, Dr. Narendra Kumar Chaudhary from Bhopal, Dr. Nehar Desai from Mumbai, Professor Dr. Colonel Prakash Chitelkar from Indore, Dr. Prashant Ganesan from Puducherry, Dr. Rajini Priya Yedla from Vizag, Dr. Rajakumar Ramaswamy from Madurai, Dr. R.S. Balasubramanian from Madurai, Dr. Rizwan Akhtar from Lucknow, Dr. Saikat Datta from Bhopal, Dr. Sanjeev from Lucknow, Dr. S.P. Verma from Lucknow, Dr. Vinay Bohara from Indore, and Dr. Vinod Gunasekaran from Trichy. Just to complete the formalities, I'll introduce our guest speaker also once again. She's MD and she's Chief of the Leukemia Services and Professor of Oncology in the Department of Medicine at Roosevelt Park Comprehensive Cancer Center, Buffalo. She directs the Roosevelt Park Hematological Procurement Shared Resource and is physician leader for the Roosevelt Park Chemotherapy Infusion Center. She also serves as an associate professor in the Department of Medicine, Jacobs School of Medicine, University of Buffalo. She earned her medical degree from University of Southern California School of Medicine and completed internal medicine residency at Yale New Haven Hospital, followed by hematology oncology fellowship training at Sloan. She has an active clinical practice caring for patients of acute leukemia, other myeloid malignancies, and other hematological disorders. Her clinical research program is focused on early phase clinical trials of novel therapies, particularly small molecular inhibitors and immunotherapy for acute leukemia and myeloid malignancies. She leads a translational lab investigating the role of marrow microenvironment in AML. She is recipient of NIH Cancer Clinical Investigator Team Leadership Award and American Cancer Society Mentored Research Scholar Award. She has co-authored over 180 peer-reviewed clinical and translational research articles in hematological malignancies and has mentored over 60 trainers. I request her to address us on novel targeted therapies in AML. Thank you, and over to Dr. Van.
Thank you so much for the overly kind introduction. I'm very grateful for the opportunity to speak to you today. So I'm just going to share my screen here. Can you see my screen?
Yes.
All right, so I'm going to talk about targeted therapies, and I'm going to talk about using them in a personalized approach. So as you all know, acute myeloid leukemia is an aggressive hematologic malignancy that largely impacts older adults who are between the ages of 67 to 70 years of age at the time of diagnosis. It's a biologically diverse group of diseases, and also can be clinically aggressive with survival in weeks to months. You can see here in the United States that the primary population that is diagnosed with acute myeloid leukemia is in their 60s, 70s, and even 80s. Shown here is a graphic that illustrates how biologically heterogeneous the disease is. And you can see that in addition to the fact that there are multiple cytogenetic abnormalities that can impact on diagnosis as well as therapeutic responses, that there are a multitude of other signaling pathways which can be mutated as well as co-mutated in patients with this disease. So when we think in our center about characterizing and treating acute myeloid leukemia, we focus now on an in-depth initial diagnostic workup, which can guide for us the use of specific targeted therapies and to make prognostic suggestions or prognostications for whether patients are going to potentially need to go to an allogeneic stem cell transplantation. So generally, when we have a patient that we suspect of having acute myeloid leukemia, we on the same day will get morphology and flow cytometry results, indicating that it is perfusion of immature blasts, as well as expresses immature and stem cell markers. We also determine lineage through the flow cytometric analysis. Within typically 3 to 5 days, or even in many centers 5 to 7 days, conventional cytogenetics and immunohistochemistry can be resulted. And again, in our center, we have the luxury of having a institute pan hematologic next-gen sequencing assay, which allows us to obtain mutation results on our patients within a short time frame. Per the ELN 2022 guidelines, I've listed here all of the genes that are mutations that that panel has recommended in an ideal world that we obtain within 3 to 5 days, and also other mutations that they've suggested be evaluated within the first cycle. I think this is an extensive list and potentially overly optimistic, but this is what are the latest European Leukemia Net recommendations have listed. Now, when we actually treat patients, we also carefully assess the fitness for intensive chemotherapy. And this is something that we've been doing as physicians for decades, for part of our entire career, is that we look to see whether patients might be eligible for intensive or less intensive chemotherapy. And you can see that some of the factors that we look at, we don't use age exclusively anymore, but we really look at frailty, their functional status, their medical comorbidities. Sometimes people use these scales where they try to predict comorbidity indices. I actually really look at their quality of life, what their activity level is, and actually also incorporate into that decision-making the goals of care that the patient articulates to me. Do they want to be cured? Do they want to live a few more months? Do they want to be comfortable? That type of thing. And in prior lectures, I've outlined sort of this as my approach. I assess the patient, the age, fitness status, and goals of care and incorporate that into my decision making along with the characteristics of the disease, as we've rather just discussed. And I select based on those criteria a chemotherapy backbone, either a low, an intermediate, or a high risk disease. And then I look for whether patient's disease might be amenable to targeted therapies, including FLT3, IDH1, IDH2, CD33, increasingly NMP1 and KMT2A, with the development of a new class of targeted therapies, the menin inhibitors, as well as P53, which is in our case, or my thinking, an indication for looking for other investigational agents. Also, depending on the same factors, would consider whether patients long-term after initial disease control would be eligible for allogeneic stem cell transplantation and or some sort of maintenance therapy to prolong their overall survival until disease recurrence. And so the one way to look at this is looking at, this is from several years ago, selecting a backbone chemotherapy, which is your base, and then adding on your novel therapies. And this needs to be, as shown here, personalized for every patient based on their specific needs and desires and wishes, just like any type of ice cream sundae might be personalized for each individual's tastes. Now, when we look at mutation status, it's important to determine, do patients have targetable mutations or do they not have targetable mutations? And I've listed here my personal opinion on some therapies that I would consider based on the mutational status of the patient. On the left-hand side are many of those backbone chemotherapies that I talked about that are somewhat mutation agnostic. And these include venetoclax and lower dose chemo regimens, as well as a higher dose 7+3. And then we also look at mutational events. Now, in the US, there are numerous targeted and non-targeted therapies which are approved for acute myeloid leukemia, as shown here. And these target or look at therapeutically directing therapy towards the underlying biology. You can see some of these are, like venetoclax, are targeted towards overcoming chemo resistance mediated by BCL2 upregulation, which upregulates anti-apoptotic mechanisms. Others are improved ways of drug delivery, such as liposomal cytarabine and daunorubicin, or gemtuzumab ozogamycin, which binds to CD33 to allow, again, delivery of a cytotoxic agent more effectively into the cancer cell. You can see FLT3 inhibitors, IDH1, IDH2 inhibitors are targeting different mechanisms, signaling pathways, and underlying metabolic pathways that are key for disease proliferation. And we do have emerging targets for stem cell biology, including galactogib. So I'd like to frame my discussion of current targeted and personalized therapies for AML in the form of two case studies to put the more relevant perspective on how these novel therapies could be utilized now and in the future for some of our patients. So my first case presentation is a younger individual, 45-year-old woman with no significant organ dysfunction, who presents with fatigue and shortness of breath. This individual has an extremely high white count of 77,000, anemia of 7, platelet count of 15, and evidence of clear acute leukemia with 77% peripheral blasts. The bone marrow biopsy confirms this hyperproliferative bone marrow with a profusion of immature cells. Further workup demonstrates normal karyotype, which is what we identify in approximately half of newly diagnosed patients with acute myeloid leukemia. And next-gen sequencing, which we'll just assume is resulted in a short time frame, demonstrates a FLT3 ITD mutation with a high allelic ratio, an NP1 mutation with a 30% variant allele frequency, and DMNT3A mutation, again, with a 40% variant allele frequency. And so the questions are, in this day and age, what would be the classification of this acute myeloid leukemia per the 2022 European Leukemia Net? What would be the recommended therapy and monitoring for the disease? And is this a patient who might need allogeneic stem cell transplantation versus some type of maintenance strategy? So shown here is the 2022 ELN risk classification. And you can see this classification is really based on patients as exemplified by this case presentation. Younger, fit patients who are eligible and are eventually treated with an intensive chemotherapy backbone. This does not necessarily reflect risk classification and prognostication in patients receiving other types of therapy for acute myeloid leukemia. And it may not predict, and we think it doesn't necessarily predict for outcomes, for example, in older unfit patients getting venetoclax-based therapy. Shown here in red are some of the major changes from the 2017 ELN risk classification published 5 years ago. You can see now that patients that have FLT3 ITD are no longer being classified based on their FLT3 ITD allelic ratio. That's been removed. Patients who have NPM1 without FLT3 ITD are now considered favorable, and those that have FLT3 ITD with mutated or without mutated NPM are all considered intermediate. You can see that FLT3 ITD has no longer, with the introduction of FLT3 inhibitors, being considered an adverse prognostic risk factor. You also see the introduction in the adverse risk category of multiple gene mutations shown here, which are predictive for what secondary AML. Secondary AML is AML that arises out of prior MDS or myeloproliferative disease. In the past, we've really relied upon patients who've had a prior bone marrow biopsy or a prior known diagnosis of a hematologic malignancy or clinical history to make a diagnosis of secondary AML. In this day and age, it's been shown that patients who have these specific, what we call secondary-like mutations, do similarly to patients that have a clinical or known history of these diseases. So we've now reclassified all of these mutations as being secondary mutations, which confer adverse risk. Shown here is the data just validating the decision by the ELN panel not to include allelic ratio in the current risk stratification, because when you treat patients with targeted FLT3 tyrosine kinase inhibitors, there's really no difference in their overall response or outcome based on FLT3 ITD allelic ratio. We also have now seen, with the introduction of targeted therapies overall in all of these patients, that some of these mutational events can also predict for addition of what we typically in the previously thought were mutation agnostic chemotherapy. So gemtuzumab is typically added to intensive chemotherapy for patients with favorable risk disease, those with inversion 16 or translocation 821. This data that was just published online last week and was presented at the ASH 2022 meeting suggests that patients that have NPM1 mutation with or without FLT3 ITD can benefit in terms of their event-free survival, as well as their cumulative rate of relapse from the addition of at least one dose of gemtuzumab ozogamicin during induction chemotherapy and to at least one cycle of consolidation chemotherapy. You can see, although the overall survival was not different in these older, mostly 50 to 68-year-old patients getting intensive chemotherapy, there was a statistically significant difference in event-free survival and about a 12% difference in cumulative incidence of relapse in patients treated with chemo alone versus gemtuzumab plus chemotherapy. Now, in this older patient population, there was significant mortality. You can see about 20% of patients died within the first 30 days. However, overall response rates as complete remission and complete remission with incomplete count recovery was very high in both groups, 80 to 90%. So this is something that we're considering now for all of our patients with NPM1 mutant disease, is the addition of gemtuzumab ozogamicin. We know for patients with FLT3 ITD, as in this patient case, that they would benefit from the addition of a FLT3 tyrosine kinase inhibitor based on this data from the ratified trial from 2017, demonstrating improved about 7% difference in overall survival in patients who had FLT3 mutant disease who had received midostaurin in addition to intensive chemotherapy. We also know the results of this ratified trial were somewhat tainted or influenced by the use of allogeneic stem cell transplantation in patients in first complete remission. And you can see here that independent of whether patients received midostaurin or placebo, they did better when allogeneic stem cell transplantation was performed as part of consolidative therapy. The patients you can see here that did the best were patients that received midostaurin and then received an allogeneic stem cell transplantation. So this is something we're potentially going to be offering to this individual patient. What about newer tyrosine kinase inhibitors? Well, the results of this trial, Quantum First, were recently published just a few weeks ago or last month in Lancet journal. And this was a randomized phase 3 looking at a second generation FLT3 inhibitor, quizartinib, which exerts activity only against patients with FLT3 ITD mutations, not FLT3 tyrosine kinase mutations. As you can see here, patients up to the age of 75 were randomized, who were fit for chemotherapy, were randomized to receive 7+3 quizartinib or 7+3 placebo during induction as well as consolidation chemotherapy. In contrast to the ratified trial, the quizartinib was also continued as maintenance prior to and sometimes following allogeneic stem cell transplantation and was maintained for up to 3 years. And you can see here in this data of these patients that there was a statistically significant improvement, again, in overall survival of patients receiving quizartinib versus placebo. This placebo, however, did not include midostaurin. So there are some key differences between this trial and the ratified trial. First of all, the ratified trial included patients up to the age of 59. The Quantum First included patients up to the age of 75. There were different mutational populations included. Quantum First only included FLT3 ITD patients who tend to have a worse prognosis than patients that have FLT3 TKD. And there were differences in how long the tyrosine kinase inhibitor was maintained in patients in both trials. When you put them side by side, which technically you're not supposed to do, but everybody does, these are two different trials, two different phase 3 trials, different patient populations as highlighted here. The question remains whether the quizartinib, the Quantum First data represents a significant clinical improvement versus what we saw with midostaurin. So you can see here very similar increases in overall survival. I would say these curves look extremely similar to me. You can see that they diverge very early on during the first 3 or 6 months of therapy, suggesting that most of the benefit of the tyrosine kinase inhibitor occurs early on. Once you get to 12 months and beyond, again, very similar results between the two trials. You see really the curves are parallel, but there doesn't seem to be further differentiation other than what happens in the first few months of treatment. So in our country, the quizartinib is undergoing regulatory review with a potential decision and possible approval of this agent for use in the upfront therapy sometime this summer, and I have heard as early as June. But the question remains whether this additional targeted therapy really represents an improvement upon what we saw previously with the ratified trial. So what would we do for this individual patient? Now, if we go back, we discuss her. So what would be her ELN risk classification? I think based on the ELN 2022 classification with her having NMP1 mutant disease with FLT3 ITD, she would be considered an intermediate risk patient. The recommended upfront therapy, what could include gemtuzumab plus 7+3 based on the results of the Lancet publication. However, looking further at that particular publication's patients who had FLT3 ITD disease did not necessarily fare better or worse with the addition of the GO. So given the fact that she has a FLT3 ITD mutation, I would favor using 7+3 plus a FLT3 tyrosine kinase inhibitor. If quizartinib was available, we would potentially choose that drug. And currently, we would probably give her 7+3 midostaurin. Disease in our center is monitored by not only by morphological sequential assessments, but also by MRD measurements. And we utilize either or both multi-parameter flow cytometry to monitor for minimal residual disease, as well as digital PCR for the NMP1 mutation. We would recommend that this individual receive an allogeneic stem cell transplantation in first remission based on the Ratify trial. And our standard of care is to offer a post-transplant maintenance with a TKI for at least 2 years following an allogeneic stem cell transplantation. Moving on to the second case, we are often, however, faced more often than not with an older individual presenting with newly diagnosed acute myeloid leukemia. And so this is a case presentation of an older gentleman, a 78-year-old man with a prior history of some cardiac disease, hyperlipidemia, hypertension, spinal stenosis, and some pulmonary issues. So just a typical older elderly gentleman with significant comorbidities, medical issues, who presents with a new diagnosis of acute leukemia. As you can see here, this leukemia is characterized by a trisomy 8, and next-gen sequencing demonstrates FLT3 ITD mutation again, IDH1, NMP1, and then the SET2D2 mutation. So again, given the patient's age and their comorbidities, and they're maybe not as fit as our prior presentation, I think most of us would be looking at a venetoclax azacitidine-based therapy for this individual. Now, when we look at the mutational profile, we do see some mutations that could be potentially targetable. So one of the questions would be, well, similar to the younger patient, should we be using a FLT3 inhibitor in combination with venetoclax azacitidine? We talked a little bit about the new ELN classification, and we discussed that that was really used to prognosticate outcomes in patients that were younger, fit, and getting intensive therapy. So what would be the expected prognosis of this patient given the mutational events? Should a FLT3 inhibitor? What about IDH inhibitors? What would be the treatment for this individual patient? And so when you look again at both ELN 2017 and ELN 2022, in this presentation from ASH 2022, we see that a large subset of patients that were classified using these systems, that when we look at patients who received prior venetoclax azacitidine therapy, and we divide them up per these classification systems, ELN 2017 and ELN 2022, that these 3 factors listed, 3 groups that we've been using for intensive chemotherapy, do not very well at all distinguish between outcomes following venetoclax azacitidine. You can see with the ELN 2017, there is significant overlap between favorable and intermediate risk. And similarly, there is overlap between intermediate and adverse risk when we look at ELN 2022. So this does not necessarily help us. But what we can look at is the impact of other mutations. So Donor and colleagues said, well, if the ELNs don't predict, are there other mutations that could help us in prognosticating for these older individuals? And they found that there were 3 genes, FLT3, ITD, K or NRAS, and TP53, that predicted for different outcomes after venetoclax azacitidine. You can see that patients who got TP53 mutations did universally poorly with venetoclax HMA-based therapy. Patients who had FLT3 ITD or KNRAS had intermediate risk, and patients who lacked any of these mutations tended to have the best prognosis, with a median overall survival of close to 2 years. In contrast, patients with TP53 disease had on average a median overall survival of 5 to 6 months. And patients who had intermediate risk disease had a median overall survival for about a year. And you can see clearly the differences in outcome based on these factors. Now, This patient had FLT3 ITD, and similar to what we just saw in that prognostic group, other investigators have also reported that patients who have FLT3 ITD have similar to identical overlapping overall survival when treated with venetoclax azacitidine versus azacitidine alone, suggesting that this is not a superior regimen for patients that have this mutation. They also have seen, investigators here at MD Anderson and in Australia have noted that at time of relapse and patients with primary refractory disease, again, tend to be enriched in FLT3 ITD, and that these mutations actually can be acquired over the course of venetoclax azacitidine therapy. There was a phase 3 randomized worldwide trial, the LACE-WING trial, which attempted to move another second generation FLT3 inhibitor, gilteritinib, into the upfront setting for these older unfit individuals with FLT3 mutant disease. As you can see on the right-hand side, unfortunately, the comparison of overall survival between patients getting gilt-aza versus aza alone demonstrated no significant difference, but there is a significant difference you can see on the left-hand side in overall response rates, with about a 20 to 30% almost improvement in overall survival responses as opposed to overall survival with early incorporation of this FLT3 inhibitor. So other investigators have said, well, potentially azacitidine was not the best partner to be combined with gilteritinib in the upfront setting. What about combining the BCL2 inhibitor with the FLT3 inhibitor? We know that BCL2 inhibition can decrease or overcome therapy resistance mediated by chemotherapy. Potentially giving the ven could enhance the effects of the gilteritinib. And you can see here the results of a phase 1b trial looking at the combination of ven and gilt in relapsed refractory patients, very high response rates, but also significant cytopenias. And again, the overall survival obtained with these patients was potentially not ideal. This has led to the development now of triple therapy, including a targeted FLT3 inhibitor, the venetoclax, and the azacitidine, all both in the relapse and refractory and upfront setting. And these were data presented again by the group at MD Anderson using this particular regimen that they've been implementing over the last couple of years for their patients, both with relapse refractory and now in the upfront setting. Now, this particular combination, it can have significant limitations, as you can see here. Originally, the plan was to give full dose venetoclax azacitidine and 28 days of gilteritinib in combination. What the investigators quickly found was that this is extremely myelosuppressive, and that many patients, given this regimen, would not have count recovery of their neutrophils or their platelets for up to 50 to 60 days, necessitating a prolonged 2-month hospital stay, which really was intolerable in many of these individual patients. And so what they did is they then said, well, we were going to truncate the venetoclax. And so they decided that they were potentially going to only give 14 days of venetoclax. And so the plan was, or the revision was, to perform a bone marrow biopsy on day 14. And if there was wipeout or cytoreduction of the marrow at that time point, that the potential venetoclax would be held. They also went ahead and similarly decided to limit the amount of gilteritinib based on the same bone marrow results, and to reduce the gilteritinib from 120 to 80 milligrams. And you can see here, when looking at these day 14 marrow results, 93% of patients either had insufficient or insufficient evaluation, or really no evidence of blasts greater than 5% at 14 days. And 63% of patients in the refractory setting also had complete myeloablation with this triplet therapy. And looking at overall response rates, they report up to 100% response in all of the patients treated in the frontline setting, and about 70% overall responses in patients receiving in the relapse refractory setting. And on the right-hand side, the majority of these patients were MRD negative. Now, I think they're probably MRD negative because they couldn't detect any cells at the time of these marrows. But these results were highly promising. And you can see here that the 1-year overall survival of patients treated in the upfront setting is now 85%. And so the question is, should patients who have FLT3 mutant disease, should they potentially receive doublet therapy? Should they receive triplet therapy? Many of us think that triplet therapy, although characterized by high response rates, is really quote unquote not ready yet for prime time because issues of myelosuppression and long-term administration persist. And so we think about unfit FLT3 mutant patients. Really, are we going to think about giving them this type of triplet therapy continuously, cycle 1, cycle 2, cycle 3? Are we going to do something like we do for fit patients, where we give an induction of 3 drugs followed by consolidation and then maintenance of just maybe a FLT3 inhibitor monotherapy? Or should we be thinking about switching back and forth between the 2 regimens and doing something like then HMA followed by FLT3 HMA and alternating in order to overcome any therapy resistance or to prolong for these? I think this strategy might be better tolerated over the long term than something that's looking for really a triplet approach. So really many questions remain. However, when you look at initially the outcomes of these patients with triplet therapy, they are really approaching the outcomes that we achieve with intensive chemotherapy backbones. So is it possible that in the future that all patients who are getting who have FLT3 mutant disease should get a triplet regimen with a ven-aza backbone as opposed to 7+3? Would this be a potentially better way to approach the disease for all patients with FLT3 mutant disease? We just don't know. Now, this patient also had an IDH1 mutation. So the question comes up also, would you treat the IDH1 mutation? Now, we know we have in our centers, we have the availability of 2 small molecule inhibitors of IDH1 and IDH2 mutant disease. You can see here these drugs have obvious efficacy, but they have overall low OCR rates, about 20% as monotherapy, overall response rates and 40%. And this is regardless of whether you give these drugs in the upfront or the relapse and refractory setting. So clearly, 20 or 30% overall response rates, although reasonable for patients that might not even be able to tolerate ven-aza-based therapy, really as monotherapy is low. And so we know that also that ven-aza tends to work very well in IDH1 and IDH2 mutant patients. You can see here that in these data, just parsing out IDH1 and IDH2 mutant patients treated in the initial upfront therapy, that the median overall survival of IDH1 patients treated with ven-aza is over a year, 15 months. And we also have seen data recently presented in 2022 where the IDH1 inhibitor ivosidenib was combined with azacitidine. These data even look better. Here, a median overall survival of about 24 months and much less myelosuppression than we saw with the venetoclax azacitidine. Patients with IDH2 mutant disease tend to do extremely well with venetoclax azacitidine, and you can see about a median overall survival here that has not been reached. And so for this individual patient, going back to the case presentation, what would we offer this individual 78-year-old patient who had all of these inhibitors available, FLT3, ITD, IDH1, NMP1, and SETD2? I think that I think it would not be wrong to just potentially give the patient ven-aza, but I think that if I had the ability to potentially do a triplet regimen up front on a clinical trial, that would be my preferred approach, ven-aza and a FLT3 inhibitor. It depends on the functional status of the individual. If that was not available and you had a second choice, for this individual, I think that I might give this patient an IDH1 inhibitor and azacitidine because I feel that is potentially a better tolerated regimen and might overcome maybe some of the issues that we're seeing with the FLT3 ITD. So I think that patient, regardless, went ahead and got venetoclax azacitidine for several cycles, achieves an MRD negative CR, remains on an AZA for approximately 10 months, but then presents with pancytopenia and reappearance of peripheral blasts. And now the patient has recurrent disease, and the mutations at the time of relapse are identical to what you saw at the beginning. And so given these results and the relapse disease, what would be some current options for this patient at this time? And we would look at all three of these, what we call targetable mutations, and just we can discuss therapies now based in this setting. So in general, shown here in the relapse refractory setting, monotherapy with any of the drugs approved for targeted therapy or for with conventional chemotherapy tends to be poor. You can see, despite all of our discussions about targeted FLT3 therapy, ivosidenib therapy, enasidenib therapy, you can see that overall the response rates for monotherapy with these drugs are about anywhere from 20, 30 to 40%, and the median overall survival of patients is really under a year, as you can see here. And that conventional high-dose chemotherapy and conventional low-dose chemotherapy do not necessarily do any better in terms of therapy. I see some questions here, but I'm going to go through my talk and then answer the questions. Okay, so IDH1, IDH2, again, when they work, we do get patients into remission, and patients can have benefit. The median overall survival here is about 9 to 10 months. But again, over time, patients recur, and this may be because of development of resistance mechanisms, IDH1, IDH2. So in the US, there has now been the approval of a newer generation IDH1 inhibitor, and that is shown here. This is olutasidenib, and this is a rationally designed, highly potent and selective inhibitor of mutant IDH1, which has a different mechanism of inhibition than ivosidenib. And so in studies of patients who had relapse refractory IDH1 mutant disease, you can see here very similar overall response rates to ivosidenib. About 40% overall response rates, CR rates, and about 20 to 30%. We saw that there were very similar adverse events. There's differentiation syndrome that we do see with this particular class of agents occurring in about 14% of patients, as well as QTc prolongation and some liver abnormalities. So in general now, when we think about IDH1 mutant disease, we have as single agents, both ivosidenib and olutasidenib. What was interesting with the olutasidenib data is that despite very, very similar CRi rates, that the overall survival of patients getting olutasidenib appeared to be longer than what we saw in the initial ivosidenib trials. Now, these drugs have not been compared head to head, and patients who received the olutasidenib in this relapse refractory trial had not received prior ivosidenib. So it's not clear whether olutasidenib is better than ivosidenib or whether it can be used in patients who fail ivosidenib. None of the patients, very few of the patients, even who received olutasidenib in this initial trial, only like 6 patients actually had received for venetoclax. So the other question is, what about patients treated with venetoclax? Would they also respond? Regardless, we can see that we now have a number of different options for patients with IDH1 disease. We have venetoclax azacitidine, which we think is potentially leads to the best long-term survival. We have azacitidine, which leads to prolonged overall survival. And we now are potentially going to have in the near future triplet therapies. There have been triplet approaches with venetoclax azacitidine and ivosidenib, and we're looking forward to olutasidenib combinations in the near future. One of the more exciting drugs, however, in development are drugs that target a totally different subset of acute leukemias, and these are menin inhibitors. What are menin inhibitors? Menin inhibitors are drugs that target the menin complex. What is the menin complex? The menin complex is an epigenomic complex which binds to the DNA of particular acute myeloid leukemia cells and leads to upregulation of a transcriptional profile which HOXA9 transcription factor and MEIS1 transcription factor driven profiling, which leads to aberrant transcription, leukemia genesis, and a myeloid differentiation block. Now, there have been many scientists and investigators which have looked at saying this aberrant MLL or KMT2A complex is active in patients who have MLL or KMT2 rearranged leukemias. But patients who have NPM1 mutant disease also have a very similar gene expression profile involving this KMT2A or MLL epigenomic complex. So there's been lots of efforts looking at trying to target this underlying leukemia genesis process in these particular subsets. And several years ago, there were people that were looking at DOT-L1 inhibitors for these patients. What was noted, however, was that this whole MLL complex is actually driven or activated by the binding of this other protein, menin. And so the protein-protein interaction between menin and this KMT2A axis is actually essential for activation and the function of this complex. So inhibitors that would potentially block the MLL or KMT2A and menin protein-protein interaction might be a good way to turn off or deactivate this complex. And so that is in the preclinical setting, and that is what we are seeing. We have seen that the blocking of the protein-protein menin and KMT2A or MLL interaction leads actually to potent differentiation effects because it releases this epigenomic complex from the DNA, downregulates these aberrant transcription factors, and decreases leukemic stem cell self-renewal, leading to apoptosis and cell death. And so this has been very elegantly described in the laboratory. And there are numerous companies that are pursuing clinical development of these protein-protein menin interactions. Two leading companies with the most highly regarded or most tested menin inhibitors clinically are the Syndax and the Cura compounds. There also are earlier stage compounds being made by Janssen, Sumitomo, Daiichi Sankyo, and Biomeo, who has a covalently bound menin inhibitor. I'm going to show you data with two of these inhibitors, one of which was recently published in Nature. We've worked personally with this drug, ziftomenib, and you can see here that in this particular phase 2 trial, phase 1b trial, patients who had NPM1 mutant disease or KMT2 rearranged disease, which had failed multiple lines of therapy, had evidence of response. You can see here that the median lines of therapy was up to 7. About 2/3 of patients had prior venetoclax. About a quarter had prior allogeneic stem cell transplantation. Many of them had co-mutations and FLT3 and IDH1, IDH2, as in our case presentation. And overall, the response rate was an encouraging 20 to 30%. Of note, in NPM1 mutant patients, the CR/CRI rate and the overall response rate was 40% with this agent. One of the side effects that was noted, however, was potent differentiation syndrome. You can see here the bone marrow, and initially at baseline showed about 75% blasts in this individual. And after 28 days, this bone marrow was completely replaced by neutrophils, indicative of differentiation syndrome. We also have seen in patients with these diseases that there also is improvement in extramedullary disease sites. So this particular compound does have systemic effects on leukemia throughout the patients. And you can see that both in KMT2A and NPM1 mutant patients, that patients treated with this drug, certain patients did live 1, 2, and 3 years after therapy. Revumenib is the other menin inhibitor, which has undergone the most extensive clinical trial evaluation. And these data were just published in Nature about a month ago. Again, 68 patients with KMT2A and NPM1 mutant disease, heavily pretreated. In this particular trial, they involved patients that had AML, ALL, as well as mixed phenotype. And there were about 8 pediatric patients and 60 adult patients treated. Again, the the majority of which had received prior stem cell transplantation or venetoclax. As you can see here, the overall response rate was up to 53%, with about a 30% CR/CRI rate. And in patients who did have a response, in some cases, these responses were durable, with the median overall survival in responders of about 9 months. Now, it's too hard to know. There did seem to be, in this particular agent, a high number of patients responding who had KMT2A rearrangements. However, you can see the true CR/CRI rate still is in this 20 to 30% range with this agent. The revumenib has the side effect of QTc prolongation, as well as differentiation syndrome. And of note, when you look at patients who received treatment who had NPM1 mutation or KMT2 rearrangement with concomitant FLT3 mutations, you saw that treatment with the menin inhibitor not only improved things, but also decreased the FLT3 variant allele frequency. So it appears that revumenib, in addition to inhibiting the menin and downregulating MEIS1 and HOXA9, also downregulates FLT3, which we think is a putative target of MEIS1. Now, this is not to say that there's not some issues with the drug in terms of therapy resistance. You can see here that many patients who were treated with this agent initially had a response in terms of decreasing numbers of peripheral blasts, but at some point, in some cases, in fact, very quickly, these blasts regrew. And it was found that in evaluation of patients treated with the menin inhibitor prior to and following therapy, that about 38% or almost 40% of patients actually developed mutations in the menin KMT2A binding site, which were not present at the time of screening and developed over the course of therapy. So this might be, again, these cancer cells are very difficult to treat clinically, and this is just one example of how quickly some of these cells can develop biological resistance to targeted therapy when the targeted therapy is used as monotherapy. So these agents are quickly moving into trials, combining them both with intensive 7+3 backbones as well as venetoclax azacitidine. And in part, these are being developed in order to overcome or prevent the developments of these therapy resistance. Now, we also have some interesting immunotherapy. Immunotherapy has not been something that has been incredibly successful for the treatment of myeloid malignancies. We've been very disappointed over the last few years with the lack of any effective immune checkpoint inhibitors, unlike what we see in some of the solid tumor cancers as well as in the lymphoid cancers. And so one of the most promising agents for immunotherapy of AML is this agent. It's what we call not a T-cell immune checkpoint inhibitor, but a macrophage immune checkpoint inhibitor. And you can see here that typically cancer cells will overexpress CD47 as an immune evasion signal. And what happens is the CD47 binds to SIRP1 alpha on macrophages and prevents the macrophages from activating and phagocytosing the leukemia cells. Now, the CD47 is expressed on both leukemic stem cells and mature blasts, and is a predictor of worse prognosis. And treatment with azacitidine, an epigenetic agent, has been shown in the laboratory to upregulate CD47, potentially making AML cells more amenable to a checkpoint inhibitor strategy. Magrolimab, which is an antibody against CD47, as you can see here, will block the CD47 signal and then allow the macrophage now to recognize, bind, and phagocytose the leukemia cells. And so in early studies, the combination of magrolimab and azacitidine in patients for untreated, newly diagnosed leukemias was very high. There was an overall response rate in about a third of patients, which actually was very similar to what we saw with venetoclax azacitidine. But what we see here, and the difference that we're seeing with patients treated with magrolimab azacitidine, is the responses that we're seeing in TP53 mutant disease. And you can see here that the median overall survival of patients now with P53 mutant disease is 12 months, which is double what we see when we treat these patients with venetoclax azacitidine. So could this mechanism be a way to overcome the poor prognostic implication of P53? And you can see there also is very promising data and extremely high response rates when we actually add magrolimab to that backbone venetoclax azacitidine. And then both studies, both of the doublet and the triplet strategy in P53 mutant AML in particular are now ongoing. Lastly, we can see here the strategies where we are looking at other immunotherapeutic approaches, and this include antibody drug conjugates. You can see here that that patients can, that there is a newer antibody drug conjugate targeting a newer antigen on AML cells, the CD123. Again, this is very similar to our drug gemtuzumab, where we are using a drug, an antibody to bind to an antigen on the leukemia cells and bring our DNA damaging agent directly into the cells. CD123 is highly expressed, particularly on leukemic stem cells. And you can see here this profound myeloablation that we're seeing when we combine this antibody drug conjugate with venetoclax azacitidine in the relapse refractory setting. And this is also being tested again in the upfront setting as a novel triplet strategy, which is mutation agnostic for treatment of older unfit patients. And so in summary, we are now moving into what we call a precision medicine era for acute myeloid leukemia. The complexity has really been exponential. We've grown from 7+3 and maybe azacitidine and decitabine alone, now to using those strategies as backbones for our targeted therapeutic approaches. And you can see here the different backbones that we are using, and then the different mutation targeted approaches, both clinically and in clinical trials, which are available for our patients. So with that, I'd like to end, and I know that there were already some questions in the chat, and I'm happy to answer questions in person or look at the ones in the chat if there's a preference. But thank you very much for your attention. And I'd be happy to take some questions in person and then answer the ones in the chat.
Thank you, Dr. Wang. That was beautiful. Enjoyed listening to you. So you can take up questions from the chat box till somebody raises the hand over here.
Okay.
Yeah, go ahead, please.
So the first question I have in the text, what dose of venetoclax do you use for azacitidine and venetoclax in elderly patients? So the dose of venetoclax we use is really dictated by the azole that we use with it. So we typically are using posaconazole for prophylaxis for all of our elderly patients receiving venetoclax azacitidine. So for that reason, our venetoclax dose is typically limited to 70 to 100 milligrams in these patients. I think that if you use a different azole, the dose of venetoclax would be 200. If you don't use an azole, then the venetoclax dose would be full dose, which would be 400 milligrams. We also tend to, so this leads into the next question, where our typical antifungal prophylaxis is posaconazole. And do we use venetoclax routinely as an outpatient regimen? For where we are geographically, it can be difficult for patients to come every day, to come into our clinic, to get count checks and monitoring for tumor lysis during the initial cycle or induction cycle of chemotherapy. So for the majority of our patients, we have them admitted to the hospital. We also do not have the facilities sometimes to, or the ability to see these patients in our outpatient setting. We just don't have the staffing. So most of our patients who are coming in for venetoclax azacitidine-based therapies are receiving them on the inpatient setting for the first cycle. After the first cycle, the plan is to administer subsequent cycles as an outpatient, but that allows us to monitor and prophylax against tumor lysis syndrome and for some of the infectious complications that occur with that first cycle.
The role of immunotherapy in AML.
So I think the role of immunotherapy is very promising. I think that right now, however, I think T cell checkpoint inhibitor, PD-L1, CTLA, that type of thing, I don't think is effective. I think it maybe works for a very small subset of patients, but most of us don't have the ability to immune profile and do a lot of testing for exhausted T cells in our patients. So I feel like those checkpoint inhibitors are probably not that effective. I do think the macrophage immune checkpoints are very promising. Those are currently in phase 3 testing, and we're waiting for some of those results. There's a number of different companies similar to the menin inhibitors that are developing newer CD47 SIRP alpha targeted therapies. One of the side effects of the magrolimab is that it can be associated with hemolytic anemias, which you'll be hearing about tomorrow from a different lecturer, because the CD47 is expressed on older red blood cells. There's a certain proportion of patients, when they get their initial doses of the CD47 antibody, will have a hemolytic anemia and a drop in their hemoglobin of 1, 2, or 3 grams. So there's a number of companies investigating different CD47 based therapies, which are SIRP alpha based therapies that don't have that particular side effect. So I think the future for immunotherapy is very bright. CAR T cells and bispecifics, I've yet to see anything enormously promising, but again, we are continuing to explore those modalities.
The other question is about relapsed FLT3 positive AML. Can we use the triplet like azacitidine, venetoclax, and midostaurin?
I think that people have attempted that. The problem with midostaurin we have found is that it's not very well tolerated. So and midostaurin is also not as potent. It wasn't really selected or developed as a potent FLT3 inhibitor. So our preference is even to use sorafenib. We've used sorafenib. We think that's a more effective FLT3 inhibitor, or gilteritinib in combination. We have treated patients off-label with gilteritinib, azacitidine, and venetoclax, but only if there is no other options for that patient. We are not. I feel like midostaurin is just not very well tolerated, but I think that it would be reasonable to attempt that in a very refractory patient with limited treatment options.
Thank you. Other questions also for FLT3 positive AML who could not undergo transplant. Then after consolidation, can we do maintenance with oral azacitidine and midostaurin?
So that's a great question. And I think that that's a question that I literally have gone to the company that makes oral azacitidine and asked them to do that trial. When patients relapse from initially FLT3 mutant disease, as this person knows, Dr. Priya knows, about 50% of the time they relapse with FLT3 mutant disease. So half the time they relapse with FLT3 wild type disease. So theoretically, if you were trying to prevent relapse, you would use one agent for the FLT3 wild type and one agent for the FLT3 mutant disease. The problem that I have with the dual strategy is, for some of my patients, particularly younger patients, I don't necessarily think it's feasible to give one drug, much less two, for the rest of their lives. So if for example, that first case, that 45-year-old woman, say for some reason she wasn't able to go to transplant and she finished up her induction consolidation therapy, what maintenance would you put her on? I think that it would be very difficult to tell a 45-year-old woman that she has to take one drug for the rest of her life. What we would tend to do is potentially give her, I still favor giving the FLT3 mutant disease. I'm still a big, I feel like that's the standard right now. I think if they were FLT3 wild type, I would give them the oral AZA. I don't have data with the combination. My only concern is the feasibility of those continuing those agents long term.
Thank you. The other question is about the duration of venetoclax therapy when you're using aza plus venetoclax, because giving beyond 14 days leads to very severe prolonged cytopenia.
Yeah, so what we typically do is for patients getting standard venetoclax azacitidine, we typically do a bone marrow in cycle 1 around day 21. And if they don't have disease, we stop. So that would mean, and then we allow for count recovery. So that would mean realistically for those patients, and the majority of my patients that do not have disease on that day 21 marrow, they're only getting 21 days with the first cycle. The second cycle, then I would start the therapy, and if they get severely cytopenic, I potentially would truncate the venetoclax down to 14 days, as Dr. Priya suggests, and then we even have truncated it down to 7 days. We also have done things like prolong the time between cycles, so going from 4 weeks to 5 weeks. As well, and to administer growth factor to try to continue to give the drug on time. But I think the minimum amount of ven that I would give with AZA is the same amount of ven is 7 days, because I really feel like it's a synergistic regimen. So if I'm giving 7 days of AZA, I'm giving 7 days of ven as my absolute minimum.
Thank you. The other one is similar to the case that you discussed. In a relapse setting, when somebody has got FLT3 positivity, NPM mutation, IDH mutation. So will you treat this person with AZA venetoclax versus FLT3 inhibitor versus IDH2 inhibitor?
So I think that in this case, I think I'm always most worried about the FLT3 ITD, because when FLT3 ITD relapses, it tends to be highly aggressive. So I would potentially continue the FLT3 inhibitor. The alternative is to give oral azacitidine. So I feel like you could continue her on aza-ven, but the aza-ven is not going to work long-term for the FLT3 disease. So I don't think that that is a good long-term strategy. I think I would favor most of all continuing the FLT3 inhibitor. But I think that long-term, maybe to try to convince her, this person to go for a second transplant would probably be the only curative approach. But I would continue the FLT3 inhibitor. And if you wanted to add something to that, this might be the person that, again, off-label, maybe you would consider the FLT3 inhibitor, but maybe you'd do the FLT3 inhibitor plus AZA. I think that would be a reasonable strategy. I would not do the ven-AZA.
Thank you. Other question is about young people with the AML. Do you do any fertility preservation, male and females?
I do try to do some. We've noted now that for many of our patients that if they're very high white counts and they some of them may need to go to therapy sooner rather than later. And so some of those patients are very concerned about fertility. We might do leukapheresis. Unfortunately, if they have high circulating blasts, it's really not a good time, I think, to collect for samples for fertility. So many of the times what we will do is if we can try to get a fertility consultant and something, if they can wait, if they have very aggressive disease, we would give them induction chemotherapy, get them into complete remission, and then have the discussion about the fertility at that point. It is always a difficult issue. But I think it depends on the severity of their clinical presentation, whether some fertility planning can be done before induction or whether it would have to wait. I also worry about patients with significant amount of circulating blasts, whether you really want to be collecting, right, samples at that point.
Thank you. The other patient is an AML with NPM1 mutation who has gone into complete remission molecular after ven plus AZA, 3 cycles. Will you after this give intensive consolidation, or you just continue ven AZA?
I think that NPM1 is a favorable mutation, but it's only favorable in the setting of intensive chemotherapy. So I feel that if the patient is able to get intensive consolidation to more readily decrease their tumor burden, that would be my preference. And it's not clear that NPM1 is necessarily, necessarily a good prognostic indicator with ven-AZA. So I think I would try if that patient was fit enough to give some intensive therapy.
Thank you. Somebody has received 6 cycles of Ven-Aza, now in complete remission. Can we switch Aza into oral Aza?
So the oral AZA is not 100% pharmacokinetically equivalent. The oral AZA is only about 20 to 30% of IV or sub-Q AZA. It's not a direct one-to-one. So if I don't think that we can recommend at this point to substitute the oral AZA for the sub-Q or the IV AZA, just because we are not sure whether that is sufficient. So yes, somebody's in CR, they don't necessarily need the high dose AZA. Theoretically, you could use oral AZA, which is easier to use and is more convenient. I just don't know about the long-term benefit. I do know also that anybody treated with Ven-Aza is being treated with a non-curative intent, right? So in that approach, if you're not going to cure the patient, if you switch to a lower dose of AZA, I just don't know whether that would shorten the amount of time that regimen would be efficacious for.
Thank you. The other question is what FLT3 mutated patient, whether the efficacy of Aza-Ven is similar to single agent Aza.
Yeah, so FLT3 mutant disease, ITD disease, the Ven-Aza is for overall survival the same as the Aza alone. For FLT3 TKD disease, that may not be true. I think patients with FLT3 TKD museum to benefit from the addition of Ven, but the addition of Ven to Aza in patients, particularly with high allelic ratio FLT3 ITD, is not necessarily better. And that is what you can get patients into remission, but their overall survival is not longer. So I think that is why we are very interested in adding the FLT3 inhibitor upfront.
The other question is about TP53 mutated AML. Outside clinical trial, what is your induction regimen?
So our induction regimen for P53 outside of clinical trial is probably Ven-Aza, just because there are the MD Anderson group has reported that in younger fit patients who have a low allelic ratio, a variant allele ratio of TP53 under 20%, that they get a reasonable response with administration of induction chemotherapy containing an intermediate or high dose cytarabine regimen. So some of them still argue that you can give an intensive regimen for TP53 with low variant allele frequency. I don't know that that's true. I don't want to subject my patients to the toxicities of a intensive induction regimen if they're not going to do well, particularly if they have complex karyotype. So I think for those patients, if we're going to attempt to get them to a transplant, I would give them Ven-Aza. If they're elderly, unfit, they have a complex karyotype, and they have P53 mutant disease, we are in some cases just offering Aza alone or even just hospice, because we feel that the current regimens are just not effective for complex karyotype P53. And I think just this last week, we had an elderly woman from a nursing home who came in with a complex karyotype P53, and we recommended hospice for her.
Sorry. The question is whether you ever add venetoclax to 7+3. I'm
sorry?
Do you add venetoclax to 7+3 in any?
We do not at this point. We are awaiting the results of some clinical trial results to justify that, and we cannot at this point do that.
Other question is about GO, whether you give it if there is aberrant CD7 positivity together with CD33 positivity.
We give the GO independent of the CD33 positivity, because we have seen that in the Alpha 701 trial that any amount of CD33 up to 0.01% was associated with a response. So the amount of CD33 expression we don't think correlates. We think what's more important for predicting response to GO is mutations. We feel that and cytogenetics. So clearly, patients with favorable cytogenetics benefit. We now think that patients with NPM1 mutant benefit, and we've actually been giving GO +7+3 to some patients with just intermediate risk cytogenetics based on the Alpha 701 study for some time, because we think it may be associated with prolonged event-free survival, which can transition or help bridge people to an allogeneic stem cell transplantation. So in our center, anybody with intermediate or adverse risk cytogenetics, we are trying to do a transplant for them and CR1. We've not had issues with VOD or SOS in the current era with low-dose heparin prophylaxis. And if we feel that they would potentially benefit from GO, we have been adding it.
What is the role of oral decitabine, cedazuridine?
So there's many studies right now where unlike oral azacitidine, oral decitabine is 100% or 97% equivalent to the IV version. So it's a more of a one-to-one substitution. So there's ongoing trials here in the US where we are trying to actively replace azacitidine in venetoclax azacitidine or decitabine in venetoclax decitabine regimens with oral decitabine because of its equivalency. So I think that those studies are very promising. We are using it. Currently, it's only indicated in the use of high-risk MDS. So we are not using oral decitabine for AML at this time because it's not commercially approved, but we're very interested in potentially having that be a one-to-one substitution.
Young male AML, NPM1 mutation with monoallelic SEPA TAD1 domain. How will you risk stratify this person?
So I think that nowadays the risk classification for CEBP alpha is not necessarily biallelic or monoallelic, but having a CEBP1 mutation in the ZIP region. So I think if they do have that, then we would consider that patient a favorable risk. And younger patients with that disease, we would give 7+3 plus GO, and we would give GO with 2 out of 4 cycles of consolidation, and hope that that patient would not be needing an allogeneic stem cell transplantation. However, anybody that's young, even with favorable risk disease, we are doing a transplant consult and identifying donors just in case they fall into, they relapse or recur as a backup strategy.
Any experience of transplanting a relapsed AML directly without any salvage chemotherapy?
So there is that data from ASH last year saying you could go straight into transplant and you didn't need to cytoreduce. We've not had that experience for years now. We've been cytoreducing our patients and taking them into transplant. So I think that most of the time I do have to cytoreduce because unlike in that abstract, my transplant team does not have a transplant waiting within enough time to really, usually the minimum turnaround time for an allotransplant is, for 6 to 8 weeks. And so we are giving a bridging strategy. If we bridged and we didn't get great cytoreduction, yes, we might take them directly in, but most of the time we would be aiming to cytoreduce as much as possible prior to transplant.
Last 2 questions are there cases of 821 translocation where you will do transplant in CR1?
No, we do not. I mean, there was some data several years ago that the presence of c-KIT mutations in patients with translocation 21 were associated with worse prognosis, and therefore those patients should be transplanted. I think that was prior to when we were just adding gemtuzumab to those patients. We did do trials where we looked at c-KIT inhibitors, but we don't feel that right now we would automatically do transplant in any of those individuals unless the only caveat to that would be is if we found that they were MRD positive and they were persistently MRD positive after consolidation, then we would take them to transplant. But I think that would be the only indication.
And the last question in the chat box is, in a FLT3 AML post-allo transplant, on which day do you start the FLT3 inhibitor?
So many studies have looked to start the FLT3 inhibitor as early as 30 to 90 days after transplantation. I think the limit, and we are fine with that. The limitation we've had is if they've had significant graft versus host disease, then they're on significant doses of immunosuppression. We will typically not start the FLT3 inhibitor if they're on high doses of immunosuppression and have active GVHD. But typically, if patients don't have that, we would be planning to start therapy anywhere, ideally between days 30 to 90 after transplant.
Thank you. We come to the friends here. Thanks for your patience. There are lots of questions in the chat box, so you had to have a long wait. Rajkumar, your question.
Hi, sir. Good evening, sir. This was a night talk with Dr. Vang. My question is, we have little higher incidence of pediatric AML, and what is your experience in treating these pediatric AML and AYI, the young adolescents? I do have little higher proportion of these pediatric AML and AYI, and what is your experience in treating these? Do you have the experience of treating all these novel drugs in the pediatric populations?
Yeah, so I don't treat pediatrics. My youngest patients are probably about 18 years old. And we typically treat them. I know in the pediatric literature here and the pediatricians here, they have different regimens that they give for the pediatric patients. We feel that for the AYA patients, and we treat people from like 18 to 39, we treat them with they usually get an aggressive induction regimen. Some people have talked about giving cladribine or fludarabine in the upfront setting, like doing a FLAG-IDA or a CLAG based therapies in younger patients, AYA patients, because they're more likely to tolerate them. We have not at this point done that. We almost universally in those patients, if they have intermediate or poor risk disease, we will go to transplant in CR1. But would we give FLAG or CLAG or anything like that right now? We would not. But I do know that there's centers that do that. There's also people that would give double induction for pediatric and AYA patients with the feeling that more is always better. Again, we wouldn't necessarily do that unless there was some other, reason to do it. I think sometimes some of my colleagues feel that patients with a lot of extramedullary disease or whatever, but I tend to do less rather than more for those patients.
Thank you.
Thank you, Rajkumar. Ramesh?
Good evening, ma'am. My first question is how much effective is this novel agents in myeloid sarcoma and CNS involvement? And my second question is, with many novel agents coming up, will the standard of care change regardless of the fitness status?
Yeah. So the first question is myeloid sarcoma. So myeloid sarcoma, I think, is very difficult to treat. We have found that some of the targeted therapies do not work very well. They just don't have the tissue penetration to take care of patients with myeloid sarcoma. So I favor intensive chemotherapy regimens. And actually, we've given gemtuzumab as well. We really favor a cytotoxic conventional regimen for patients with myeloid sarcoma because we just don't know, like we've had some patients treated with venetoclax azacitidine that haven't responded very well. So I just worry about whether the targeted therapies are going in and get enough decrease in the tumor burden in patients with myeloid sarcoma, particularly if it's compressing or extremely large or threatening other organs. In terms of fitness and standard of care, there is a trend, I think, away from but I think there's a trend to consider other factors other than fitness and try to treat patients universally. For example, there's a lot of controversy now whether everybody should get 7+3 or maybe younger fit patients should get venetoclax azacitidine. So that is an active debate. So for patients that have, for example, poor cytogenetic or mutational risks per ELN 2022 that are not going to do well with intensive regimens, regardless of their age or their fitness, should they still be getting 7+3 when you know from up front that they're not going to do well? And I think there is a significant trend to, and there are clinical trials ongoing to treat those patients with the venetoclax-based therapy. And there's a few trials now where they're randomizing those younger patients with adverse risk. There's more than one trial randomizing patients to Ven-Aza versus 7+3. So hopefully we will have that results in the next year or two. There was some data from the Chinese group from the last couple of ASHs where they've treated their patients with Ven HMA-based regimens and seen very nice outcomes. So I think that's a great question. And I think that's something that we're struggling with right now. I think that most of us would think about giving Ven-Aza to a patient with complex karyotype or adverse cytogenetics, but an intermediate risk 45-year-old probably would still get induction. So we just don't know.
Thank you.
Thank you, Ramesh. Dr. Narendra.
Thank you, sir. Thank you, Dr. Wang, for a nice lecture. Because I'm from pediatric side, so though Dr. Rajkumar has asked question regarding pediatric one, but my question is that is there any targeted therapy approved in pediatric age group for AML?
So I believe that the gemtuzumab is approved, a CD33 antibody drug conjugate. I don't know if the gilteritinib may be approved or not. I don't know. I think, and I know that for example, the menin inhibitors, which are being targeted to patients with KMT2 rearrangements, are actively being explored. As you saw, the phase 1 trial included 8 pediatric patients, and there are separate trials ongoing in the pediatric population. The other drugs, I'm not sure whether there is, I think because of the rarity of pediatric AML, I'm not sure whether the companies have data in them. If you would like to know, I'm happy to inquire if you wanted to email me the specific drugs that you're interested in, and I could look into it. But I'm not aware, just because I don't know that they've done the studies for those patient populations. So I think a lot of them may not be approved or may be undergoing additional testing.
Okay, I think GEO was used by COG protocol, actually, AML 0531.
I think GEO is approved under 18, but I don't know about the other targeted therapies.
So what is your take on that? Should GEO be there with the standard chemotherapy protocol?
I think so, yes.
Standard of care?
I think so. I mean, I think I found GEO to be effective. I think it definitely decreases the risk of relapse, and I think it extends event-free survival.
So we should use in all patients, irrespective of the CD33 status, as you told.
I think not in adverse karyotype. So patients who have adverse risk do not benefit from GEO, but patients with favorable or intermediate risk categories, I think, who are fit enough for intensive chemotherapy, we have seen that they might benefit from GEO. The older patients, I think over 60, there are some additional toxicities, but the younger fit, favorable and intermediate risk, I think there is rationale to include GEO into their regimen.
Okay, one more question is, why the results of these novel targeted therapies are not so good for AML, like imatinib and for APML, ATRA we use. So those are having excellent response because of the target. But why not in the AML? We are having the good response.
I think that because AML, aside from those particular subtypes, is a very, as I taught, biologically heterogeneous disease. And so in addition to having co-mutations and other mutations, it's very complicated. So and most of the AML biology at the time of diagnosis is polyclonal. So you'll have multiple clones, multiple mutational profiles, and you just, with one targeted therapy, cannot get rid of them because there's not one overwhelming pathological. So like with CML or APL, you have one pathological event that accounts for 99% of the disease, right? So if you target that event, mutational event with your targeted therapies, you will have a response. But AML, you won't. You will see how many different mutations, co-mutations, there's subclones. It's incredibly biologically heterogeneous. So as soon as you get rid of one clone, another clone will arise. Or even as we saw, even with the new menin inhibitors, you'll have therapy resistance occur over the course of the disease because it's so highly proliferative and there's a high mutation rate. So it's a different animal than a disease that's solely driven by one pathogenic, cytogenetic, or mutational event. And if you target it, then the disease will go away.
Okay, thank you, Dr. Wang.
Sure.
You, Dr. Prakash.
Yeah. Thank you, Dr. Wang, for a wonderful lecture. I got one question about the development of monosomy 7 directed therapies. Are they in the pipeline, or is it?
So, I mean, I think for, I don't think specifically for monosomy 7. I think that we are trying to develop therapies such as magrolimab immunotherapy that are cytogenetic and mutation agnostic. You know, if you can activate the macrophages and you can activate the immune system, then maybe you don't have to specifically target the cytogenetic abnormality, or you can overcome some of the clonal heterogeneity. I'm not sure if there's any specifically directed monosomy 7 other than the agents that we've been developing to try to overcome some of the overall adverse cytogenetic and mutational profiles.
Thanks. But another question is the presence of an FLT3 mutation in a condition like acute promyelocytic leukemia. How do you manage? I mean, we had a patient recently.
Yeah, so acute promyelocytic leukemia is often characterized by FLT3 mutations, and most of the time they are association with the APL clone. So if you give them the arsenic or whatever you're giving them, gemtuzumab, then it will disappear with the disappearance of the major clone. And so I don't think that there's any reason to be concerned. The FLT3 mutations in APL do not confer worse prognosis because most of the time the prognosis of the APL is so good, and they tend to be eradicated when you eradicate the underlying stem cell clone. So it's not something that we're concerned about in that disease.
Thank you.
Thank you, Prakash. Dr. Deep.
Thank you, ma'am, for this excellent lecture. My question is, do you use FLT3 as an MRD marker for patients on TKI inhibitors?
We do not at the current time, but there are FLT3 next-gen sequencing assays that have been developed. And for example, in the Quantum First trial where they use quizartinib 7+3 versus placebo 7+3, there's recent publications showing that the use of FLT3 next-gen sequencing PCR can be used as a marker for FLT3 disease. So I personally don't use it at this time. The reason that we don't think it's as reliable an MRD marker as, for example, NMP1 is that the FLT3 mutation is very promiscuous. It can be detected at diagnosis, it can disappear, it can emerge over time of therapy. It's not a static mutation, unlike NMP1, which is an initial driver mutation and tends to stay constant throughout the disease course. FLT3 can come and go. So I think that it's probably best used in the setting where you're going to give a FLT3 targeted therapy to see whether you've gotten rid of all of the FLT3 mutant clone. But as a marker for overall disease, it's unreliable. As I mentioned, when you treat people with 7+3 midostaurin, 50% of the time they're going to recur with FLT3 wild type disease. So they could have 50% BLAS and your FLT3 ITD next-gen sequencing is going to be negative, but that they have active disease. So that's the problem with the FLT3 to use as a constant MRD marker.
Thank you, ma'am. And also I have another question. You mentioned about sorafenib, ma'am. So for how long do you prefer sorafenib maintenance for patients who are unfit for transplant?
I've given sorafenib for years in some patients. In general, there are some long-term side effects. Patients can have cardiac toxicity, but I have had a patient who had FLT3 mutant disease, went to transplant, and had recurrence post-transplant, and I put them on a FLT3 inhibitor as well as azacitidine. The patient remains disease-free. So it's not sure. I think many of us, the one way to potentially utilize this in the future would be I have some of my colleagues that give a FLT3 inhibitor for 2 years following transplant. And then and this might be the ideal setting, they would then do a FLT3 next-gen sequencing, PCR, MRD assay testing. If that assay is negative after 2 years of post-transplant maintenance, one of my colleagues has discontinued the FLT3 inhibitor, and he states he hasn't had recurrence at this time. So I would advocate potentially 2 years and then doing an assay and then consideration of tapering off.
Thank you.
Thank you. Dr. Chandrasekhar.
Good evening, Dr. Wang. Thank you for excellent talk. Am I audible?
You're audible.
Yeah. My question is that, is there any role of venetoclax maintenance in post-transplant setting or post-chemo setting when patient is in CR, particularly where we don't have targeted mutations, and in Indian setting where we don't have luxury to use all targeted drugs which are available in US?
We have not used venetoclax in the post-transplant setting. We found that it tends to be myelosuppressive and there's infectious complications. We also have issues with, just obtaining the drug because it's not approved in the setting. I wouldn't use it just because I don't have any data. And I mean, I think that some of us have used low-dose hypomethylating agents for maintenance in that setting. There are ongoing trials looking at venetoclax and azacitidine, but until I see those results, unfortunately, I can't recommend it just because of the potential toxicities. But it is an intriguing idea, and if there's no other options, I think it might be worthy of further study, but I just don't know.
Thank you.
Dr. Verma.
Thank you, ma'am. Just a clinical scenario. I have a patient, 72-year male, who was diagnosed with AML monosomy 7 in 2019, and I started him on single agent azacitidine. He was there on azacitidine initially for 7-day cycles for 1 year, and then I had to decrease in the concern with the patient, and then 5 day schedule, and then 3 days, 2 days. So he has been in remission for the previous 3 years, and the last dosing schedule was 2 days of azacitidine per month. And with that, he was in remission for 6 months. So overall, he has been in remission for last 3 years. Now, for the last 2 months, he has developed progressive cytopenia. And then again, the bone marrow is showing 9% blast with the progressive cytopenia. I had increased the azacitidine dose to, again, 7 days protocol for last 2 cycles. But he is still having this persistent cytopenia and no improvement. So what should be the next step in this patient? Like, should I shift to decitabine based therapy, or should I add venetoclax? And now he's 75 years old with the persisting cytopenia. So what should be the next strategy in this
Right.
case?
So I think your persistent cytopenias are because your disease has come back. And so I do think that everybody treated with an HMA therapy. I've never cured anybody with an HMA therapy. So at some point the disease will recur. I think that increasing from 2 to 3 to 7 days of azacitidine is probably not going to be effective. You could try switching to decitabine. There's probably about 10 or 20% of patients that would respond when you switch the HMA. But I think at this point, probably more effective would be to add venetoclax to your regimen. Or switching to what I have had had success with is going in these patients that have received multiple cycles of HMA. I have switched to venetoclax low-dose cytarabine because and do a venetoclax LDAC just because they've received so heavily pretreated with their HMA that you may not get more effect by switching, and that might be switching to an LDAC approach or an LDAC ven. I think I would add ven either to preferentially LDAC and just try something completely different if the patient can tolerate it, or you could try adding the ven to the HMA, but their patient may be resistant to the HMA regardless, just because they've had such continuous exposure.
Yeah, thank you, ma'am. Thank you.
Thank you. Ma'am, 1 or 2 more questions have come up in the chat box. Do you do RNA sequencing in all AML patients at baseline?
We do next-gen sequencing. We don't do gene expression sequencing, but we do we have done RNA-seq or gene expression profiling in experimental settings, but we have not found it to dictate clinical care.
Right. And one question I think you already answered. Are there situations where azacitidine venetoclax treatment can be stopped?
So there is a case study that was published in Blood Advances where Dr. Andrew Way and Courtney DiNardo and some other specialists that treat a lot of patients with venetoclax-based therapy presented a dozen cases where patients had NMP1 mutant and or IDH2 mutant patients preferentially who had excellent responses to venetoclax azacitidine. And after a year of ven-aza therapy, they stopped therapy on those patients. Now, I would highlight that in every single one of those patients, the disease recurred. And all of them at some point had to resume therapy at some point, maybe a year or two later. But they looked at a number of similar patients that had continuous ven-aza therapy, ven-based therapy, and they said that there really was no difference between stopping and continuing. So there may be select patients that you could stop, the caveat being that the disease will come back, but you could take some time off. I'm not 100% sure that I could identify. I'm not doing it routinely, but I do think in select of these very elderly patients, if they are not able to tolerate or they have issues of tolerability, it could be something you could consider. What I have done in a number of patients is I have gotten them into remission. They're not tolerating the ven-aza because of cytopenias, and I've just dropped the ven. Okay, I've just given them, like as the prior speaker said, just a tiny bit of aza every month. At some point they're going to recur, but for quality of life issues, we have done that in some patients. And so therefore, I think it's reasonable to, if you needed to halt, just knowing that it'll come back.
Thank you. Deep, you have more questions?
Yes, one more question.
Go ahead.
Ma'am, we have a patient of AML with translocation 821 who is currently in remission after 3+7 of therapy, 3+7 chemotherapy. This patient also has c-KIT mutation. So what would you advise for this patient right now? Should we go ahead with upfront transplant or should we consolidate with IDAC and just observe this patient? And GEO was not used for this patient.
Yeah, so I think that if they're still MRD positive, if they haven't gotten consolidation, I would go ahead and give consolidation and see whether you can make them negative with consolidation. If you can, potentially there might be a role for maybe some KIT inhibitor maintenance, or you could add, I don't know about the benefit, you could try adding GO to day one of your consolidation if you'd like, or I think it's unclear whether you would get any benefit from GO if you didn't use it in induction. So I think I would maybe go forward with standard consolidation, see if we can make the patient MRD negative, and then you could consider doing some sort of maintenance therapy after finishing of consolidation. Doesn't necessarily mean that they needed to go to transplant. If they remained MRD positive after consolidation, then I think I would consider transplant.
Thank you.
Okay.
Right. So I think there are no more questions. So thank you so much, Dr. Wang. This was a very, very long session. New patient answered every question. Really, everybody must have tremendously benefited. We are extremely grateful to you.
All right. Thank you very much for the opportunity and enjoy your evening.
Thank you. Bye-bye.